What's up, y'all, and welcome back to my channel. And I am Nurse Lopez, if you didn't already know, and I am back with a new orientation feelings. So I am now in my 9th week. I have already worked 2 days this week out of 4, so I have 2 more left, and my orientation length is 10 weeks. So after this week, I have 1 more week, and then after that week, I have 2 weeks of education along with orientation before I take the test that I told y'all about. So the last time that I did a new nurse orientation feelings video, I was at the beginning of my 3rd week of orientation, and my feelings are 10 times different in a good way for the most part. And I only say that because the last video, if you didn't already watch it, I was basically letting y'all know how I had got thrown into dialysis, didn't really know anything. My 2nd week after like the office material and learning and stuff, and I was already on the floor like running. So now that I have actually finished my workbook for my company and went over everything, learned as much as I could, now I am actually in the experience and actually doing hands-on stuff more and by myself individually more at this point of my orientation. So the plan is to become tandem or do tandem. I don't really know how they say it, I just really know what it is. Next week, where that is basically I get my own patient, my own 2 patients while in the room with the other nurses, and if I have any questions, then I can ask, but for the most part I will be responsible for those patients and doing everything from start to finish myself, which I kind of not like scared or anything about, because I feel like sometimes I basically do that myself. Just like the other day, I felt like I basically ran the room myself because the other nurse is not trained to the acute room area, but I've oriented mostly all my time in there, so I kind of know some stuff that they don't know or whatever. So I'm not really scared or anything, and other than that, I basically do that stuff anyway by myself. So I know I also talked to y'all about not even just the last nursing feelings video, but other videos I have mentioned how I am really struggling with morning shift, of me having to get up so early and be at work, and then like my hours and stuff. And I was actually given the opportunity to, I guess, work later in the day, like come in at 10, but just work my shifts be longer, like I wouldn't leave till later. But the only thing is with that made me choose to not do that is because I don't think that I will get the same amount of hours if I do choose to do that, because we don't usually have that many patients past a certain point. So on a good day, yeah, maybe, and they wouldn't have to do so many patients at the beginning, so I could do them at night. But on the days where we are getting off early or only have like 1 or 2 patients, that would be a waste and I wouldn't really get to work. So to keep my set hours and everything, I'm just gonna stay with the morning shifts. So also, I just found out that we have a new nurse starting in the next few weeks, so I won't be the newest nurse. Now I will still be the youngest nurse, but and a new nurse, but I won't be the newest for my facility, which I'm kind of happy about. I kind of wonder who it is that's going to be precepting them. Not that there is anything wrong with my preceptor, but I wonder if it'll be one of the CCs, the clinical coordinators. And I've also have thought about that and everything that the other clinical coordinators and nurses have told me, and basically with where I am now with my orientation and how they feel like I'm learning like so fast and doing everything so fast and so good. A lot of them have told me basically to work up the company as fast as I can, especially with me being so young and starting off so early. They feel like it won't be hard for me at all to work up in the company, so like to be a clinical coordinator, manager, and so on and so forth. but I feel like I will eventually do that. But right now I'm just trying to get like comfortable in my position to where I kind of know everything. Like, I've been through everything, seen everything, even if I don't do it like multiple times. Yeah, so the reason why I say that I feel like so much better is because, like I said, I'm doing mostly all of the stuff now that I couldn't have seen myself doing my 3rd week. When I talk to y'all about, I'm also starting to learn and basically be able to read trends with the dialysis machine settings and values enough to be able to recognize when certain things are going on and when to react. So for example, I've learned, and most people who watching this video know nothing about dialysis, know nothing about dialysis nursing. So basically on a dialysis machine, it shows the arterial pressure, which is negative because we're pulling the blood out of the patient, and then the venous pressure, which is positive because it's going back in. TMP, which is usually linked to clotting, the venous pressure, venous port, and other factors that affect it. And then also the order is on the screen, so the temperature of the dialysate and the water in the system, the amount of time that the treatment is going to run, how much fluid we're going to take off, and a few other things. So basically I'm able to recognize when a patient blood is clotting off in the middle of the treatment now. So last week, I want to say it was Friday, we had a new start patient, and when I say new start patient, they've never had dialysis before. They just got a port put in, and now we're starting their dialysis for them. So about 52 minutes into their treatment, the variables, so basically when the patient's blood is clotting, the venous pressure will go up and the TMP will go down. So for example, venous pressure was originally the whole treatment 150, and the TMP has been 50 the whole time. When the TMP goes down to 20 and the venous pressure went from 150 to 250 in a short period of time and just like a steady rate, more than likely they're clotting off. So yeah, I had the patient, and I think about 52 minutes left of the treatment, I was doing a 15-minute check, and the levels were the exact same, because as I look over and like chart the patient's variables like on the machine and just about what they're doing and if they have any complaints or anything, I basically compare the other results up until that point to make sure no variables has changed that I need to be aware of. The BP is okay. They not having no reports of any hypertensive episode, signs and symptoms, or anything like that. So her lab values and everything was fine. I literally like turned around to ask the question to the nurse real quick and turned back around, looked at the machine to finish writing the variables, and the TMP dropped really fast, and then the venous pressure had went up. Now sometimes it does that if they like move or any other reason, like that wouldn't have to lead to a complication. So usually we just press the little restart or whatever the button is to basically restart the system to get it back acting right and call it a day, because most times that's the troubleshooting method that works. But this time it didn't, and it just kept on going up, and I'm like, in my head I'm thinking they clotting off. So with me not being confident enough, because I've never like necessarily recognized and seen that myself, I turned around to the other nurse and was like, I think that they are about to clot off. And so she had hurried up and got up. And the reason why that's like an emergency, or not an emergency, but like a stat thing like to handle or whatnot, is because if they fully clot off, then you're not able to give that blood back that's in the bloodlines in the machine. back to them because it won't run back through the lines. So you usually want to act fast when it comes to that, so you can give them the blood back to them so they won't lose it, because that's a lot of blood that they will lose. So basically at the end of that, it was clotting off like I said, and the nurse was really happy that I was able to basically recognize that and see that enough to say something to her, with the fact of that I have not yet learned what to do specifically with that. So she just pushed the normal saline and through the lines to kind of help with the clotting and break it up, or get it to where it would move out of the place that it was, so if we needed to return the blood. So we did end up having to return the blood, and the doctor just told us to cancel the treatment because they were going to be running tomorrow. So that was all good and dandy. And then yesterday I worked with a different nurse, and we had the same patient. So after you have patients like that and things happen like that, so like maybe, you know, a patient, every time he comes in, he has a hypertensive episode, or she clots off every time that she comes in, or she has a chest pain every time she comes in, you start to like recognize that and know like what to look for whenever those patients come in. Regardless if I am acute or chronic, we usually get a lot of the same patients over and over again through the hospital for whatever reason. So we had the same patient, so I let the nurse know that basically they clotted off the other day, so like we need to watch the levels for like a drastic change really fast. So the whole time, like I think we had about 3 patients in there at once, and it was a PCT there also. So she was the one mostly taking down like the lab values and everything for the patient for most of the treatment. And then one of the 15-minute checks, I went up to do the 15-minute check, and the VP, the venous pressure went up, the TMP dropped, and I was looking at it and I was like, I asked the PCT, like, has her venous pressure been 50 this whole time, or her TMP been 50 this whole time, and her venous pressure, whatever it was? And she was like, I think so. And I was like, well, because now it's 190, and I think she's starting to clot off because she did this the other day. So I told the nurse too, because yes, I'm a nurse, but it's still some things that I still have to make sure, like with the other nurses, even though like I know like what I'm talking about. So the nurse came over, and the difference between this nurse and the other nurse is the other nurse acted first, and I guess favor of the patient losing the blood rather than calling the nephrologist first. But this nurse wanted to speak to the nephrologist first before deciding what to do with the patient. So this day or yesterday, her levels started changing faster than they did the first day. So when I went downstairs to go get the heparin that the nephrologist had ordered for the patient, it was 190. But when I got back, it was like 3 something. And I was thinking in my head, like, we're not going to be able to get his blood back, because with it being that high, that means that it's been clotted even more. So we weren't able to run the blood back to the patient, so we just gave her some fluid, normal saline at the end to replace what she had lost. Also, the doctor had told me to give heparin, which didn't work because it was just too far gone at that point. So he wanted us to restring it and give her a IV push of heparin, which I did before we connected the system back to her. And she ended up clotting off that line too. And I think it took 3 times for the doctor to finally say, just forget it. So I don't really know what they're going to do with the patient, and if they're going to start her on heparin before or whatnot. But I just felt really good because, like, as a new nurse, when you find out that you actually like know the stuff and like actually are learning from your experiences and from a book to where you can actually act on it in real person, like, you're gonna feel so good. Like, I felt so like proud of myself and so happy with like the point of my orientation process where I am now, because I don't know, I'm just really proud of myself. But yeah, so I've done a lot of stuff that I didn't think that I would ever do. I've given blood, I think, to 2 different patients, so I'm more familiar with like how to prime the tube in, where to put the tube in, because it's different than if you was just giving it to the actual patient, because we have to do it to the actual port rather than the patient IV site or wherever a regular nurse would do it. I've given albumin for BP drops. I have talked to the nephrologist myself, and I've learned how to change orders based on the nephrologist telling me to, and I've given heparin. I have not ran heparin through the actual treatment, but I've given, like I told you, IV push twice within this week. And I don't know, I just feel really good because I've been really like working hard to where I can learn and listen and try to put like what I read to what I know. And if I would not have read through my book binder and like took notes on it again, I probably would not have actually understood the way to recognize clotting like I did. So I do recommend, and I think that I actually am going to do a video on how to be like a successful new nurse. But I just feel like if you do have learning like that, and when you first start out, you're not going to understand what it's talking about at all. So if you just read through the first time, and if you want to, like, this is usually what I do in nursing school also. I read through it the first time and take notes the second time, which I did, and that has helped me tremendously. So yeah, I do really feel good about it. I'm getting over the morning shifts, like even on the days when I'm like dreading to get up because it's so early. I don't usually dread actually going to work, but it just be the time that I have to go to work. Usually my patients kind of make it up for me because a lot of them I've worked with since the beginning of my orientation, so they've kind of seen me grow from like not knowing anything and having to check before everything I do to now basically running the treatment by myself. Like a patient that I had the other day, like I know that whenever the patient comes in, to make sure to ask if or have them tell me when they having chest pain or hip pain, because the patient will go in AFib really fast and it'll cause chest pain and all of these other problems. So I make sure that whenever I have the patient, I ask those things and I look at the telemetry monitor to see if AFib is going off and all that type of stuff. And they told me the other day about how they really appreciate every time that I take care of them. I take care of them like really, really good, and I make sure that they straight through the whole treatment and all of that. And I do feel like that this is an important thing. It's something that I have learned is about being a patient advocate. Like I said with the doctor situation, if they're about to lose all of their blood, I feel like it would be better for you to just like return the blood and do second, and like if you need to restring and do whatever you need to do, and do that afterwards. Regardless, like, you're going to talk to the nephrologist in general, but I mean it's protocols for that, so I just gotta learn which method is better or read which way that I'm actually supposed to do. I feel really good right now. I think that I do like my job. At first I was honestly thinking that maybe dialysis was not for me, but now that I'm getting like where I am and even further, I think I do like it. But we'll see, because I probably won't know till like a year after working there, or 6 months at the least. But thank y'all again for watching my video, and I hope that you like this video and the content that I provide. Don't forget to like, share, and subscribe if you like my videos. And the next video will probably be about dialysis nursing or another experience that I go through. But yeah, I will see y'all later. Bye, y'all.